What if unexplained infertility isn't actually unexplained? In this episode, I sit down with Dr. Kristin Kalinowski from Veritas Fertility and Surgery, and we unpack the real reasons behind miscarriage, PCOS, blocked tubes, and even male factor infertility. The things many couples are never fully told. If you ever felt like you didn't get the full picture at your doctor's office, this conversation is for you. Do you long to get pregnant and trust your body again? Do you feel exhausted by the month after month cycle of hope and disappointment? Do you carry that creeping sense of failure? The fear that your body just isn't working the way that it should? If so, I'm so glad that you're here, my friend. Hi, I'm Mariana, a wife, mom, and a fertility care practitioner. After years of confusion and heartache, I learned how to understand my cycle with clarity and move towards pregnancy naturally by following a real system instead of guessing. This is Fertile Window Lab. If you're ready for real clarity about your cycle, a simple method that works, and less pressure from predictions, alarms, and fertility gymnastics, sit down the sticks, pop in your earbuds, and let's make sense of your fertility together. Hi, TTC Warrior. Do you want to hang out with other women who are serious about understanding their ovulation and getting real cycle clarity? Inside my free Facebook group, Trying to Conceive, Ovulation, and Cycle Clarity for Women, you'll learn how to better understand your fertile window, how to read your cycle with confidence, what might be disrupting your fertility, and what to actually do next. If you're done guessing and ready for clarity, come join us. And if you want deeper guidance, become an insider, get weekly emails from me with advanced fertility education, mindset coaching, and practical next steps you can apply immediately. You'll find the link for both in the show notes. I'll see you inside. Welcome back to the podcast. Today we're talking about something that many couples experience but rarely receive clear answers: infertility, miscarriage, and the real root causes that often go unexplored. Dr. Kalinowski, welcome to the show. Before we dive into the topics, I'd love to hear what drew you into restorative reproductive medicine and working with couples who are trying to grow their families.
Thank you so much, Ariana, for having me. I am so honored and delighted to be on the podcast, and I really respect the work that you're doing, just helping to spread the word about fertility awareness and restorative reproductive medicine. So my journey into the field was pretty organic and intuitive. I've always been interested in medicine, even since I was a little kid, so my path into medicine was pretty straightforward. And when I was in med school, I knew I loved the field of OBGYN and our patient population. Just dealing with women of all ages, but especially women of reproductive age, was super rewarding for me. And I was blessed to work with some mentors during med school and my OBGYN residency who shared this restorative reproductive medicine approach, where they were practicing in a way where their goal was to identify the underlying cause of their patient's symptoms and then to address that cause with targeted therapies. And this stood out to me because, unfortunately, in the general world of OBGYN, that approach only goes so far. And especially in the world of fertility, it is more common to do a basic evaluation and then end up jumping straight to something like in vitro fertilization or artificial insemination. And for multiple reasons, that approach didn't resonate me. And just on a medical level, it didn't resonate with me because in every other field of medicine, it's standard to try to identify the underlying causes and pathways of the problem, and then to come up with treatments that restore things as close to normal as possible. So when I discovered this field of NaProTechnology and restorative reproductive medicine within OB, it really rang true for me. And so my training since that point has been geared towards this pathway. I did my residency at Mercy Hospital in St. Louis, where there was a physician, Dr. Gavin Putoff, who's my partner now at our practice. He was practicing at that hospital, so I got to work with him during residency. And that's when he started to discuss with me joining the current practice, Veritas, to work with him and do this medicine full time. And then after I graduated residency, I joined our practice and I did an additional year of an apprenticeship with him, where I learned more detail about the approach that we provide. And then I also completed the Creighton Model medical consultant training through the Paul VI Institute in Omaha in that time as well. And I've been with Veritas ever since, and it is so rewarding being in this field and able to be part of the stories of so many women and families walking through infertility, recurrent losses, as well as just other gynecologic issues like pain with periods and abnormal bleeding. So I'm so blessed to be here.
Wow, that sounds like you had your training and now you can able to help a lot of families. So we like to transition. One of the questions that usually comes up often is when couples are trying to conceive and their fallopian tubes are blocked. And they're usually told, your only option is to move into artificial technologies or just accept the fact that you won't be able to conceive naturally. What usually causes the tubes to become blocked?
Yes, Mariana, this is such a great question. And I see this on at least a weekly basis. Super common. Tubal factor infertility occurs at least a quarter of the time, so it's very frequently encountered. And there are different types of blockages. So think of the fallopian tube like a little hose or straw coming off of the top of the uterus on each side. So you can have blockages right at the connection between the tube and the uterus, blockages kind of midway down the tube, and then blockages at the end of the tube. So there are different ways that they can get blocked. And those blockages that are close to the openings of the tube at the uterine level tend to occur either from a prior infection of the abdomen and pelvis, from inflammation within the tube, and that can be kind of an autoimmune condition, as well as just debris or mucus that, like menstrual products that normally go out the uterus during the cycle, sometimes those end up wedging at the tubal opening and just getting a little bit inflamed, and then it creates a blockage that way. So sometimes it's as simple as that, and then the tube remains blocked and nothing's able to pass through. For blockages further down the tube, it can also be secondary to pelvic inflammation from something like a past infection. But additionally, this is where inflammatory conditions like endometriosis come in, where there's this nodule of inflammatory tissue outside of the tube, but it creates enough inflammation near that area where the tube gets pulled into this band of tissue that pinches it shut.
So how can doctors determine if the tubes are actually blocked? Is it a test for it?
Yes, definitely. I'd say the standard test that most patients are familiar with and oftentimes have already completed when they come to see us at Veritas would be a standard HSG, or a hysterosalpingogram. And that's an office procedure where they put a little catheter inside and inject some X-ray contrast, and they're watching to see if it fills the tubes. The issue here is that when they're injecting the contrast, they just put it in the uterine cavity and they're not able to direct it selectively into each fallopian tube. So there's a more detailed test that we offer called a selective salpingogram. And with that procedure, it can still be done in the office, and it tends to be very tolerable for women. They often say it's less painful than an HSG because we do it under much lower pressure than an HSG. But we have a little catheter that can go up to each tube one at a time, and then we can check the tubes in that way. And if there is a true blockage, it will show up on that test. And HSG has a high false positive rate, where because of the high pressure that is used, sometimes the tubes will cramp shut and it appears that there's a blockage when maybe it's not actually blocked. So the selective salpingogram is a nice way to get around that. And the bonus here is if there is actually a true blockage, at the same time as doing that test to diagnose the blockage, we can try to open the tube. So there's a really flexible, tiny little wire that can be gently guided inside the tube to break through any blockage and clear the way so that the tube is reopened. And we have a lot of success with that procedure. I can think of a patient that I saw recently who came to me with this very common story saying, I was seen at a IVF clinic They did an HSG and both my tubes are blocked. And I was told I had to do IVF to get pregnant. And she had searched online, like, is there any way to open the fallopian tubes if they're blocked? And she found us. So in our consult together, I walked her through what the selective salpingogram would be like. And she came in a few weeks later to do the test with me. And I was able to open both of her tubes. She conceived shortly thereafter. And we got an email from her recently saying that she had delivered, she sent her baby pictures, and she was able to conceive naturally without needing any treatments that were kind of artificially bypassing the blockage that she had. So this is an awesome resource we have at our disposal, just doing this test. Unfortunately, it's not offered at a lot of just standard fertility clinics or even hospital radiology departments. It's very dependent on the training of the provider that's doing it, whether or not someone even knows how to do it. So we're happy to offer it at our clinic.
That gives a lot of my listeners a lot of hope. But one of the questions that I usually get is, how do I know? Is there anything that I will notice beyond not being able to get pregnant that my fallopian tubes are blocked? Or is it something that you consider as a standard care for you to investigate?
Sure. Fallopian tube blockages can sometimes be completely clinically silent, and the only symptom might be infertility. So I would say that's fairly common, and we see that at least half of the time. If there's a blockage at the end of the tube, in that case, there tends to be more symptoms, and those symptoms could include pelvic pain, abnormal discharge or bleeding patterns like a brown discharge or spotting in between periods, pain with intercourse, pain around ovulation. Those sorts of things would be more common if the tubes are blocked towards the end of the tube. But often if it's a blockage right at the start of the tube as it's coming off the uterus, you might not have any symptoms at all from that one.
Yeah, I often hear also that women are told only one of the tubes is open or partially open. And a lot of women automatically assume half of their chances are gone. How can you explain that to a woman that even if one fallopian tube is open or in good condition, what would that lead in terms of pregnancy?
Yes, even if there is only one functional tube, there is still a good chance of pregnancy. And I think the key thing here is time. We know that frequently with ovulation, the tube that is on the side as the ovary that released the egg for that month, it's easier for that tube to pick up the egg. So like for a woman with one tube that's open, maybe her right tube, if she ovulates from the right side, she's more likely to get pregnant those cycles than if her left tube is blocked and she ovulates off the left. It's a little harder for that egg to get picked up by the right tube. But it's not 0%. We see it pretty frequently where someone ends up conceiving from the opposite side tube, it picks up the egg from the opposite ovary. So there's definitely, it's not just 50-50, it's probably still higher. But then when you factor in time, for women with only one tube that's open, if you give it twice as much time, you're still going to have the same overall rate of conceiving. It just might take a little bit more time. And it's probably not exactly twice when you factor in that the egg can kind of move around and get over to the other side, at least some of the time.
I only have one fallopian tube and one ovary. Sadly, one of them was gone. I lost it during an ectopic pregnancy. So I always give my own testimony, but I wanted them to hear from you that is very much possible. I have a 3-year-old son running around, one fallopian tube, one ovary, and my pregnancy was healthy. So it's always best to hear from the doctor.
One patient I treated within the course of the last year, and she had a really significant endometriosis that was so bad it had destroyed one of her tubes. So I had to take that tube out because it was beyond the point where it could be fixed, and to enable us to remove all of her endometriosis, that tube had to be removed. And then she only had the one tube left. And interestingly, we were walking through additional fertility treatments for her. So we were doing these monitored ultrasounds while she was taking medication to help her release eggs. And we saw that she released an egg on the side that didn't have a tube. And we were sort of like, we'll see what happens. And that was the cycle that she got pregnant. And same thing as your story, like where it was the opposite tube that was able to pick it up. So we know this happens. It's not quite as easy for it to happen as if it was the same side, but it happens all the time.
And moving into endometriosis. Endometriosis can be silent. A lot of women struggle with endometriosis, and maybe their only symptom is infertility. I know this is kind of like your expertise. What can you share with us about endometriosis causes, or even like what's available for them if that is their current diagnosis?
Definitely. Yes, Ariana, endometriosis is a leading cause of infertility and super high prevalence in patients with infertility and pain symptoms. But also, we see cases of silent endometriosis. So, for women without pain with periods, but they have infertility as part of their story, half of those cases, endometriosis will be present. It's a factor. So, this is super common. And what's happening at pelvic level with endometriosis, this is where cells that are normally found in the lining of the uterus, like the type of cells that are coming out with the period each cycle, have implanted somewhere outside of the uterine cavity. So they're just kind of in the abdomen and pelvis. And when that occurs, these cells, they're still hormonally active. So they respond to all of the normal hormones that are circulating from the ovaries and the brain. Because they're in the wrong place, they create inflammation. And it's like inflammatory toxins that are spreading around the whole abdomen and pelvis. And that can lead to scarring, and the scarring can obviously block the tubes or affect the ovaries so they're unable to release the eggs as well. But even if there's no scarring, all of this inflammation can hurt the quality of the eggs. It can affect the way the tubes transport things. The uterine environment isn't as optimal, so maybe the embryo can't implant as well, or the sperm is getting damaged as it passes through. There's a higher rate of hormone deficiencies in women with endometriosis, and it can even lead to decreased cervical mucus. We see that as well. So those are some of the fertility effects with endometriosis. I'd say the next most common symptoms would be pain with periods and abnormal bleeding. We see those symptoms very frequently as well with endo. But it can cause many other symptoms, including pain with intercourse, miscarriage, higher rate of ectopic pregnancy, bowel symptoms like bloating and GI dysfunction. As far as treatment options, I'd say there are two broad categories. We think about the medication route versus the surgical route. With medications, I think the highlight here is that it is more of a symptomatic approach and kind of a band-aid therapy where you're trying to suppress pain and maybe abnormal bleeding symptoms. But there's no evidence showing that adding hormone suppression or ibuprofen, NSAIDs, those types of meds, stops the endometriosis from spreading or improves the fertility outcomes or makes the endo go away. So it's kind of like if you had a fire and you threw water on it, you've put out the flames, but you still have the hot embers there. That's like the medication route. Surgery is a different approach where you can actually try to get at the root of the issue and remove the endometriosis. So this is a path that we frequently walk down with our patients. And we would always do endometriosis excision. That is the gold standard and the best treatment that's out there where we can completely remove the endo. So we would trace around anything that looked abnormal and shave it off, peel it out, and leave healthy tissue behind. This is in contrast to the standard approach. Unfortunately, a lot of OBGYNs are trained in fulguration, where you just burn those spots. And the issue there is that you might be missing endometriosis below the surface. So if you think about if you were trying to pull all the dandelions from your yard and you're just ripping the stems off, but you leave the root, that root, it's going to grow right back. So that's kind of what happens if you're just burning the endometriosis. So it's important to make sure if you're going down a surgical route to do the excision because there's a much lower chance of it coming back. So the most common outcome that we see after we've surgically excised the endo is that pain with periods completely improves or goes away entirely. We've had a lot of patients say now I get surprised by my period. You should have left a tiny bit of endo there so I could know it was coming. We're like, no, you don't want any endo left. So we never leave endo, but they make jokes about that, and the pain tends to improve significantly. And then the fertility rates also improve significantly. We see fertility rates on average of around 60 to 70% after an endo excision, which is above fertility rates for any of the artificial reproductive technology treatments that are out there. And then this is just good for health. Not only are you improving your natural fertility outcomes and reducing pain, but women who have endometriosis that's untreated have a higher risk of developing scarring over time. During pregnancy, if they were to conceive with the endo there, they have a higher chance of things like preterm delivery, abnormal bleeding, preeclampsia. Not only will it improve some of these things in the short term, but you're also looking ahead thinking, what is best for my health in the long term as well.
Yeah, that was in a nutshell everything they need to know about endometriosis and how can they get help. And I'm so grateful that you mentioned that the different techniques and what are the downsides of choosing a different type of technique, because that's one of the questions that I get. What about regrowth? If, how can I prevent regrowth? Thank you. So another painful experience that many couples face are recurrent miscarriages. So they are coming into the system because nobody can tell them why they are not able to keep a pregnancy. What are some underlying causes that exist that are causing recurrent miscarriages?
Yeah, this is such an important topic. And I think couples that are struggling with recurrent miscarriage are in their own, it's an especially painful and isolating journey because you have all of the joy of getting that positive pregnancy test. But then when you have a loss and then another loss and loss after loss, it becomes something that's so fraught with fear and just anticipation of yet another episode of grief and loss, truly, where this is a child that you were excited for and ready to welcome, and it did not work out that way. So we see this frequently, and I am so mindful of our couples as they come to us who are walking this path, just knowing the place of grief and suffering that they're already. So our approach with recurrent miscarriage is the same sort of theme as our approach with every other problem, whether it's a fertility or gynecologic problem. And that is systematically walking through every known and possible cause that could decrease chances of healthy function here. So we think about structural causes, and I would say this is something that even like a standard fertility clinic does an okay job with, depending on where you go. So we would always look for a uterine septum, scar tissue in the uterus, a fibroid that might be pushing inside the uterine lining, affecting implantation. So those are things that can be assessed with an office test called a saline ultrasound, and it's pretty straightforward and it can give us a good view of things. We also have the ability to put a tiny camera directly inside the uterus in the office and directly visualize the uterine cavity. And that can give us a different view of the same sort of thing. If there's a polyp or something in that space, that would be another cause of miscarriage. A detailed assessment of the uterine cavity, though, should also include testing for a chemical inflammatory process that can really increase risk for miscarriage. And this is called chronic endometritis, where the lining of the uterus itself has become inflamed. And this chronic inflammatory pattern develops where it's just a feedback loop and it keeps going. And oftentimes there is bacterial colonization involved there. So it can be skin bacteria or vaginal flora that has managed to ascend inside the uterine cavity and kind of set up shop there, and it leads to this inflammation. And this is a test that I'd say is frequently missed, like with a more sloppy approach, but it's super frequent cause of losses and miscarriage, especially for couples struggling with recurrent loss. So it should always be checked. Again, this is an office procedure. We do it and we just do a biopsy and cultures from inside the uterus and look for inflammation. And if it's present, we can treat it with a short course of antibiotics. There's an added benefit when you biopsy the lining of the uterus. You create a little scratch, so to speak, that growth factors go to that area to help it regrow. And the first few cycles after doing that biopsy, there's a higher chance of an implantation, even if you did nothing else. So that's another benefit of looking at this test. For some of our recurrent miscarriage patients, though, it's not so much a structural cause as a hormonal or chemical cause. And in those cases, we are definitely aided by a large panel of blood tests that we order for all of these patients. So we think about thyroid function, other endocrine disruption like prolactin levels. Especially important would be the luteal phase hormones. So these are the hormones that the ovary should be making every cycle after the egg is released. Estrogen and progesterone are being produced from the ovary. And especially if the progesterone level is running lower than it should be, this makes the lining of the uterus less healthy and less stable. So if you're having an embryo that tries to implant and grow there, if the lining is unstable, there's a higher risk for a miscarriage. So we can check these levels specifically timed to the woman's cycle. And if the levels are too low, we can add bioidentical supplements to help boost back to a normal range, and that can significantly reduce the risk of a loss as well. So there are a bunch of detailed blood tests that are available to us, and we often kind of fill in the gaps of more detailed tests that maybe someone comes to us and they have some of this done, but the more extensive and thorough stuff hasn't been completed yet. We can order all of that and make sure we're addressing all of the possible variables.
Something that surprises many couples is that they were able to conceive once, but now they're struggling. What are some of the causes of what we call secondary infertility?
Great question. And we see this very frequently through our office. I'd say the most common cause of secondary infertility in couples who don't have a surgical history, so there has been no C-section, would be either endometriosis or an ovulation disorder. And endometriosis, what's tricky there is that it can develop at any time in a woman's life. There have been cases of endometriosis starting before the period even starts, and also cases postmenopausal. Those are exceptions, but it just illustrates this is a disorder that can develop at any point in a woman's life. So that's pretty common to see, as well as the ovulation disorders, where these can also pop up over time, where previously maybe it wasn't an issue, but then something changes just with the hormonal signaling or structurally with the ovaries, where the eggs aren't developing or releasing as well. For women, though, who have had a history of a prior delivery, and if that delivery was by C-section, I would say the most common cause of secondary infertility in those cases would be a C-section scar defect. And that's where the area at the bottom of the uterus where the C-section cut was made might not have healed as well as it should have, and it creates a little pocket or a niche that can catch inflammatory fluid and affect fertility. So that's something that we really keep on our radar, especially for women that had no issues conceiving, delivered by a C-section, and now they're coming to us saying, hey, it's been a couple years and we've been trying, no luck. That should be the first thing that is assessed if a C-section is part of the history.
And I feel like or I have heard women say, oh, my mom had endometriosis, and it's kind of like they assume it's genetic. And then also we think like, oh, I had one baby. Why now things change? And we don't have an answer for that. And we just think it's something that we did. And there's a lot of guilt and shame that comes with blaming ourselves, something that we did or didn't do, or we didn't ask, or even a woman that needed to have a C-section for medical reasons. And I was like, oh, I did something, or I choose something. Are there any treatments when it's related to a C-section?
Definitely, yeah. With a C-section scar, there are two treatments. We have a vaginal procedure where we can use a simple no incision approach to smooth out the area where the C-section defect is, using a little instrument that helps sort of shave down the speed bumps that are catching the inflammatory fluid. So that is a great option when the C-section scar, maybe it has a little indentation there or a niche, but there is a thick muscle overlying the area still. So it's safe for us to just shave it down, smooth it out, and make it in line with the rest of the uterine contour. The other surgical fix for this would be a laparoscopic or robotic repair. Place small incisions in the abdomen, and we're able to access the scarred area through the abdomen. And this is the approach that we take when the scar is super thin. So if there's not a lot of muscle left in that area and it's just a few millimeters, almost paper thin in some cases, if you tried to shave, it's really not the safest because you might end up making it thinner or poking through. But also that is a weak area for future pregnancies. So it's high risk that thin scar, if you don't fix it, it could burst open and threaten mom's life or baby's life if that happened during pregnancy. So in those cases, when the scar is dangerously thin, it's best to do this laparoscopic robotic repair where we go through the abdomen and we just trim away that whole thinned area, and we put together the thick edges so that it's smooth and strong again. And when this heals, it's as if the woman had one C-section that healed perfectly. So in most cases, she would be safe to do a trial of labor and try for a vaginal birth in a future delivery. And her risk of that uterus bursting open in a future pregnancy remains low because her scar is now healthy and as strong as it can be. So we offer both of those surgeries through our office. And I think in the US, we're the only, probably in the world, we see the most of this condition as anywhere else. So we see it pretty frequently, at least a few times a month, if not more.
Especially because C-section rate is so high for whatever reason in the US. Without getting much more into detail, I am counseling through my own services is couples that already had 3 C-sections and they're like, I'm being told not to have any more. It's almost like in the standard recommendation. And so there's a lot of fear. What will you respond to those clients? Obviously, there is a personal evaluation to assess the uterine cavity, but it is being given pretty often, like no more than 3 sections. Right. It will risk your life and it creates a lot of fear.
Yeah, I think that's a great point, Ariana. And it comes down to a lot of the time experience of the provider that's performing the C-sections. In my area, in the St. Louis area, I know of a OBGYN who frequently treated women who were growing large families and would have, up to, I can think of one that had up to 12 C-sections. Her first one had to be a C-section and everyone since that needed a repeat C-section. And with the techniques that he used, meticulous surgical technique and closing the uterus in multiple layers with non-inflammatory sutures, being really mindful of scar tissue prevention, he was able to safely walk with that family through 12 C-sections, right? So part of it is inherent in the experience. And I think there's a liability factor where maybe OBs, it's easy enough to put someone on birth control. So they're like, it's safest, don't have any more children. You had 3 C-sections. But part of this also is a evaluation shortcoming where a lot of OBs aren't even aware of how to test for a C-section scar defect or a uterine isthmosele. They don't know that the saline ultrasound is the way to look for that, and they don't know there's a way to fix it. So there needs to be more growth and education in this area too, just among the OBGYNs, where they understand if someone has had 3 C-sections, yes, we need to be thinking about their risk of a uterine rupture and the risk inherent in another C-section. But part of that thought process should be performing an evaluation of the uterine cavity with a saline ultrasound to see maybe her scar is totally perfect and she would be safe to have 5 more C-section deliveries. You need to look to know the answer there. And then if you do see that it's thin, that it wouldn't be safe, then you refer to someone that can perform the repairs. And at that point, then you kind of reset. The uterus is back to a place where it's healthy and it's ready to expand and grow with a growing baby. So I think that's part of it, just a lack of awareness and a lack of exposure to some doctors in their training to this condition. And then also kind of the easy fix approach of when in doubt, birth control, which unfortunately it seems like it's been a default in the world of OBGYN for years now, many years.
Sadly, we don't have an upper doctor in every city, just like we have OBGYNs, but it's good that we know that there are some. And I always tell my clients the fact that we have them in the US, the fact that we have a few per state, especially I'm in Los Angeles, there's a few in my area. And even though we have to drive a couple hours, they are within driving distance. So looking for the right doctor and according to our goals. And if we have a specific goal, then let's do our research. But moving into, we talked a lot about women's fertility, and we know there is another factor in the fertility process, which is the male factor. Are there any ways to assess or treat male factor infertility that align with the method like a restorative approach? Because if a man fertility or is a male factor, again, 50-50 mentality is like, oh, if this half of the equation is not working properly, are our chances then reduced to an artificial technology?
This is so important. I'm really glad you brought this up. And I think for patients that are coming from different ethical or religious backgrounds too, this can be a factor where the male factor evaluation can be a roadblock through the standard approach for collecting a semen analysis or the treatments that are offered. And our approach there differs. Frequently, the first step in a male factor evaluation is checking the sperm, and that's a semen analysis. The way we have our patients get this specimen is they have intercourse together with an at-home collection kit that has all the instructions. There is a perforated condom that allows them to collect the sample, but still be open to the possibility of conception with that active intercourse. And then there's a preservative liquid that comes in the kit. So you just put the sample in the liquid and you ship it with the mailing stuff that's included through the UPS store that same day you collect, and we get an accurate result that way. So that's a way I think that fits in more with the NaPro approach for collecting a semen analysis. And then from there, when we see our results, we're thinking about, is there enough sperm? Is it moving normally? Is it shaped normally? And are there signs of other problems like oxidative stress or low volume, that kind of stuff? Excuse me. So all of those answers, for the most part, come back on just a basic semen analysis. If we're looking at oxidative stress, that would be a separate test. But from there, frequently, there are treatments available that are simple, like an over-the-counter multivitamin targeted towards sperm health. And we can offer recommendations for these based on what we see on the results. I think I've had patients come to me sometimes, Ariana, that they tell me like, yeah, we were told my husband's semen analysis was bad and he should do IVF. And I review the semen analysis and I'm like, yes, his movement, the motility is low, but look at his concentration. It's super high. So this is kind of balancing itself out. So I think it's important when we're analyzing results from these tests to fit all the pieces together. And I think sometimes that's not the assessment that a couple has had when they bring their results to me based on what they're telling me they've been told by their other providers. So I think just keeping that in mind is really important, and we can provide hope that way too. Sometimes we run into structural issues where, depending on what the semen analysis looks like, we might recommend that a couple pursue an evaluation from a urologist, and they can test if there's anything wrong with the veins draining the testicular area where it could actually have a big impact on the sperm, and there is a surgical fix available for that. So those are helpful resources to work with a fertility urologist that's able to do the structural assessment for us as needed. And then finally, there's growing research and evidence that even if the semen analysis is normal, there might be oxidative stress that's affecting the quality of the sperm. And that can be assessed with a more detailed test called DNA fragmentation. And this is something that it's not included on like an at-home semen analysis kit, but it can be assessed through a urologist's office. And that would be another thing that can add to the evaluation and the treatment if there's male factor affecting the fertility as well. And then just focusing on lifestyle. A lot of the time for men struggling with infertility, simple changes like weight loss, limiting alcohol intake, decreasing or stopping smoking. Those are things, it seems basic, but sometimes guys haven't thought about this stuff. And making those changes can significantly improve the sperm. So we always screen for those things and double check that there's not something in the background with his health, like diabetes or something that could also be optimized to help improve the sperm.
And leading with that, diabetes and insulin resistance, which is one of the few causes of polycystic ovaries. What is often misunderstood about polycystic ovaries, or if PCOS can be treated?
Great question. PCOS is so common. We see this in at least 10% of reproductive age women, and it has significant impacts on the cycle as well as fertility in a lot of cases. I think women in general don't have a good sense of what is a normal cyst and what is an abnormal cyst on the ovary. And we all have this lack of understanding, I think, because no one in general teaches it. Like when you're growing up through biology and like health classes, like in general, this is not covered. So we tend to think like any cyst is a bad cyst, and this is not actually the case. A normal ovary should have cysts in it. That's good. That's where the eggs are. But what I think about with PCOS is that you kind of have too much of a good thing. There are extra cysts, and all of these extra cysts produce extra hormones. So then those hormones go into the bloodstream and your brain is seeing it, and the brain just gets disoriented by the extra hormone levels. It's not quite sure where you are in the cycle. So this leads to dysregulation of the normal signaling between the brain and the ovaries. So women with PCOS tend to see irregular ovulation, irregular cycles as kind of the downstream effect of their irregular ovulation. And then with all of these imbalanced hormone levels, it can also cause other symptoms of high testosterone, like excess hair growth, acne, hair loss, insulin resistance tends to be part of the PCOS picture. So it's a complex interplay of all of these signals and hormones going back and forth. But I'd say the default treatment that a lot of women are offered with PCOS would be, if they're not trying to conceive, they're told to do birth control, just to kind of override the hormones. And then if they are trying to conceive, maybe they'll be offered artificial insemination and letrozole. But then if they fail to conceive within 3 to 6 cycles of that, immediately to IVF. And there's extra risk for women with PCOS undergoing IVF because the strong medicines that are used to stimulate the ovaries to make eggs can actually dangerously produce too many eggs for the PCOS ovary. So that woman might have 20 eggs and her ovary might get super big, very painful and very dangerous. So it's extra risky to do ovarian stimulation and IVF in these cases. Our approach with PCOS is to try to use a more holistic root cause approach and address the underlying hormonal imbalances that are present. So the first thing is lifestyle. If weight is outside of the normal range, like if a woman is overweight, even losing 5% of her current body weight can restore normal ovarian function. So we start there. If we have room to make progress with weight loss, perfect. And we work with a fertility dietitian, and we also sometimes end up recommending to help enhance weight loss. Additionally, there's a natural supplement. Myo-inositol is super helpful for women with PCOS. And adding this can improve fertility rates and ovulation a lot of the time, and very few side effects. So low risk, simple way of trying to help. We often will use medications to help people with or women with PCOS to conceive, but we do this in a different way than maybe a standard fertility clinic. We would always start with ultrasound monitoring during the medication treatment course to confirm that the ovaries are responding the way we need them to and that we're using a safe dose. So we would always do that. But especially if someone wants to avoid using medications every time they're trying to conceive, or maybe they want an approach that also provides benefit and improvement in some of the other PCOS symptoms, like maybe they're dealing with all this excess hair growth or insulin resistance. There are nice surgical approaches available to help with PCOS. You can remove some of the excess ovarian tissue with a minimally invasive laparoscopic surgery, reconstruct the ovary using anti-inflammatory techniques to help it heal, and this brings the ovary closer to normal. The hormonal signaling that comes from an ovary that has had one of these PCOS surgical treatments, an ovarian wedge resection or drilling, that hormonal signaling is much closer to normal or totally back to normal. So then 90% of the time after one of these surgeries, we'll see regular cycles every month without meds. And we see the fertility rates go back up to 75%. And normal is 80%. So almost back up to normal, just with the surgical treatment for PCOS. And the added benefit there, because you've reset the hormonal balance, some of those other symptoms that also go along with PCOS should improve as well. So this is a really useful treatment that, again, it's not widely offered because I think a lot of OBs just don't encounter it in their training, and then they're trying to jump around the problem instead of get to the root cause of the problem.
And last but not least, there's another factor that couples encounter, which is low egg reserve. They're like, I don't have a lot of eggs. I think just going the artificial technology is much safer. So it gets very discouraging. What would you say for somebody that has been told that the egg reserve is really low and they would just encourage artificial technologies?
Great question, Ariana. This is a more and more commonly encountered issue that we're seeing, especially as women are working on growing their families and trying to pursue fertility later in their lives. But also this can happen early in someone's reproductive years. Like I've had patients in their 20s dealing with low egg reserve, and there's multiple causes of this. But a lot of the time we can't identify the actual underlying reason for why the egg reserve has dropped. Sometimes, though, there's a genetic component, and we definitely think there's an autoimmune element here. But when that is the case, it can be really discouraging for couples because they're frequently told, you have to do IVF or do donor eggs. You don't have a chance of conceiving on your own. What's important here is that AMH, anti-Mullerian hormone, which is the blood test that a lot of doctors will order to check egg reserve, is a measure of how many eggs could be harvested if you're doing IVF, but it's not actually a measure of fertility. So that's one thing. Sometimes a patient will come to me saying, my AMH is too low. They said I can't get pregnant. And that's not necessarily the case. It just means that if you gave medicine to try to retrieve eggs, you might not get a lot of eggs. So AMH doesn't directly correlate with fertility. There are other labs and other assessments, including a detailed ultrasound, that should be performed. But if we do have a situation where the other hormones show that the brain is seeing this as a situation where there aren't enough eggs, in that case, the ovaries might not be releasing any eggs because there truly are not enough eggs to even release one a month. And that's a situation where it can feel hopeless, but there are good treatments available. So we have a supplement that we would always start called DHEA, and this can boost the egg reserve and the health of the ovary so it's able to respond more normally to hormones. So that's a simple one. But we also have a novel new research technique called platelet-rich plasma, where we can inject some of the PRP, the patient's own plasma, into the ovary and rejuvenate it. And there are new studies coming out that have been looking at this, showing benefit from that. So it's a way to directly deliver like growth factors and anti-inflammatory chemicals right into the ovary with a needle to get it right to the source. And that helps perk the ovary up a little bit so that it can do better with releasing eggs and responding to hormones the way it should. So using this technique, we can see a boost in the egg function and the ovulation as well as fertility within the first 6 months after doing that procedure. So I think it's a really useful tool, and it provides hope for a lot of patients who might have been told that if their egg reserve is low, IVF is their only option.
For couples who've been trying to conceive for a long time and feel discouraged, what message of hope will you want them to hear today?
You're not alone, and we are here to walk with you through this process. I would say any NaPro doctor or doctor focused in restorative reproductive medicine is here as a resource for you. I'd say a lot of the time, not all of the questions have been answered. And when there are unaddressed questions, like there's always hope to be able to find a cause that maybe hasn't been investigated, because that's not the mainstream approach that a lot of fertility clinics will take. So I think with the NaProTechnology and restorative reproductive medicine approach, we see fertility rates that are as good as and better than the fertility rates that would be achieved through a standard IVF, IUI approach. And on the other side of things, you're also getting answers for what might be affecting fertility. And sometimes that's half the challenge, walking the infertility path, not just feeling like no one is able to give you an answer for what's going on with your body and why things are not working out the way they should. So I would say most of the time with this approach, we're able to help couples conceive and grow their families and have success in that way. But even if we're not, there can be so much peace just having more information and knowing that we left no stone unturned and we're working to restore natural health with this approach. We see such great results with it. So I think there's a lot of hope for couples who might have been told IVF is their only answer using this approach. So we're really blessed to be able to offer these resources and to walk with couples through their journey and their story.
Thank you so much, Doctor. Thank you for joining us today and for the work that you're doing to restore women's health and support couples with compassionate, science-based care. In this podcast, we believe that woman deserves to understand her body, to know that her health matters. Conversations like this remind us that our fertility is not just about getting pregnant, it's about restoring the whole person. And thank you for being here, sharing your expertise to our listeners.
Thanks so much for having me,
I'm my mama's little fertility helper. If this episode has helped you, or if you feel a little more hopeful, leave a review. She'll love it.
Hi, DTC Warrior. I hope you enjoyed today's episode. If so, please leave a 5-star written review on Apple Podcasts. It truly helps to get this show into ears of more women who need it. And be sure to sign up for my weekly encouragement, tips, and insights straight to your inbox. I promise to keep it practical, hopeful, and faith-friendly. All right, I'm off to tacos, chocolate, and try my cycle. I'll meet you back here next week. Bye.